paper. Unfortunately, we are over time, so really there is no time for questions. And I'm going to ask my co-chairman, Dr. Salman Al-Qurashi, to present the next speaker.
Our next speaker is Dr. Abeed Pall, who is currently a consultant renal transplant physician at King Faisal Specialist Hospital in Riyadh. Dr. Abeed Pall is going to speak about viral infection, important virus in transplantation. Please welcome Dr. Abeed Pall, and looking forward to hear from you.
Well, thank you, Mr. Chairman. I'd also like to thank Dr. Shaheen and the organising committee for the invitation. I'm grateful to you all for staying here. Last talk after 2 days of the meeting. It's not easy to listen to this, but I hope you can bear with me. So my talk is going to be on viruses in transplantation. Clearly, I can't cover all the viruses, so we will focus on just 2 or 3. Now, I think it's important to recognise that the traditional timeline that we all are familiar with and that we use and has been very useful to us in terms of assessing patients' risk of different infections is evolving. And this is evolving. We've heard about new donor-derived infections, but other interventions have also changed this timeline. And this is because of the types of organs that we're transplanting, the new strategies in terms of prophylaxis, preemptive strategies, the use of various drugs and possibly also vaccines which are coming into the scene, emerging viral infections, the intensity of the immunosuppression protocols, and some of the newer immunosuppressive agents which may actually have an adverse effect, such as the concern with belatacept in terms of CNS lymphoma and EBV disease, and but on the other hand, maybe antiviral with regard to the everolimus, which we know does seem to have some potential for activity against CMV and BK. Now, as I say, there's a growing family of viral pathogens in transplantation, and we're only just beginning to think about the interaction of these viruses in individual hosts. I'm going to focus on the herpes viruses, cytomegalovirus and Epstein-Barr virus, which are important in all solid organ transplants, but as well as that, we'll look briefly at polyoma BK virus, which is an important cause of renal allograft loss. Now, what I've tried to do here is, in simplified terms, just to outline the thinking and the approach to viral infections in transplantation. Essentially, infection results from active viral replication, and with seronegative individuals, this is a primary infection. We can also get reactivation of a latent infection, seropositive recipients. Latent virus itself has a particular characteristic, such as being persistent, also retaining that ability to reactivate, but also can induce proliferation and oncogenesis. Eventually, if we don't stem this infection, some patients will progress to disease, and this may be a viral syndrome, straightforward fever, cytopenias, or we may get more invasive disease involving the varied organs. And also, as I've suggested, cellular proliferation and malignancy is of concern resulting from these primary infections. What we try and do is, at the outset, we try and risk stratify our patients and initiate some form of prophylaxis where we can. Otherwise, we will look for and monitor for evidence of viremia, and using established cutoffs, or cutoffs that we're trying to establish, we may introduce preemptive strategy there. This may allow us to intervene. The crux of intervention really is reduction in immunosuppression in almost all these 3 agents. We may opt to change the immunosuppression, and there's various data which we'll go into. There may be the option to use an antiviral agent and other specific treatments, and ultimately we may end up having to treat the disease itself. So the recommendations that I'm going to imply or suggest during the course of this talk come from 2 very important guidelines. First one was from the Transplantation Society, which is from the International Consensus Guidelines on CMV in solid organ transplantation. That was published in Transplantation last year, and the KDIGO guidelines on the care of the kidney transplant recipient, published a couple of years back. So the first case I just wanted to share with you was a 64-year-old lady who received a living-related transplant in 2006. She was serostatus for CMV and EBV was positive for donor and recipient. She received induction with basiliximab and then subsequent maintenance with tacrolimus, Cellcept and prednisone. Prophylaxis was with Septra for 6 months and ganciclovir orally 1 gram TID for 3 months. In 3.5 years later, beginning of last year, she presented with a 6 months history of weight loss, around 10 kilograms, recurrent severe abdominal pain post-meals. There was no history of fever or bowel disturbance. She was found to be anemic, hypoalbuminemic. Her graft was working well with serum creatinine of 67. The CMV screening and the blood revealed negative for antigenemia, PCR was negative and culture was negative. She did have a positive EBV titer of uncertain significance at this stage. In view of her symptomatology, we focused on the abdomen. She had an ultrasound of her abdomen and also an upper GI endoscopy, which were unremarkable. We went on then to do a barium follow-through, and this identified clearly a very abnormal area in the terminal ileum, which was diseased with a stricture and ulceration. She then went on to have visualization of this area by colonoscopy, and the terminal ileum was clearly, again, inflamed, erythematous. There was areas of erosions, generalized edema, and exudates as well. Biopsies were taken, and the biopsy at the top left, you'll see this as an abnormal lamina propria with interstitial infiltrate or lymphocytes and plasma cells, and there were also some larger cells here, and high power of that identified a characteristic CMV inclusion. So we came to a diagnosis with much perseverance here, in this case with CMV ileitis. The patient then went on to have her immunosuppression further reduced. Cell-set was stopped, tacrolimus dosing was reduced. She was treated with intravenous ganciclovir for a period of 2 weeks, and then subsequently oral valganciclovir for another week, and then subsequently maintained prophylaxis. With that, symptomatology improved, and she made actually quite a dramatic improvement in terms of weight gain as well. So CMV is still one of the most important complications in solid organ transplantation, significant morbidity and occasionally mortality. Infection is evidence of replication. Disease is infection with symptoms, which may be the viral syndrome and or a tissue invasive disease. I think it's also important to remember that CMV, like some of the other viruses, and this was shown very clearly for CMV, was early infection can have effects much later on. And this paper by Sagadel showed this very clearly, that patients who had asymptomatic CMV infection in the first 100 days, these patients in this cohort received no induction, no prophylaxis. The study monitored for CMV antigenemia weekly. They found 60% of patients developed antigenemia. Those that had an infection, this did impact on the overall risk of mortality with a follow-up period of 66 months of about 2.9, and those with CMV disease, the relative risk was 2.5. So this is unexpected, really. You certainly expect immediate difficulties, but I think this highlights that the impact may be further down the road. The risk factors for CMV, we're all familiar with this, the serostatus, the highest risk group, those which are donor positive, those are seronegative recipients receiving a donor positive kidney or other transplant, and those who have intermediate risk are those where the recipient is seropositive and receives either a donor positive or a donor negative transplant. The lowest risk is amongst the seronegative recipient and donor, where the incidence perhaps is in the region of 5% of developing CMV disease. There are other risk factors, and clearly the type of organ that's transplanted has an impact. The lung and small intestine having the greatest risk, liver, kidney the least. And this is due to a number of factors, possibly due to the organ load, due to some kind of immune reaction within the organ itself, and also the level of immunosuppression. So the intensity of immunosuppression is important, and the net immunosuppression. When we talk about net immunosuppression, it's not, I think it's important to remember, it's not just the drugs that the patients are on. Other co-infections can have a significant effect on the net immunosuppression as well as their comorbidity. HLA-DR zero mismatch seems to have an increased risk, and in some transplants, heart and lung in particular, but not liver, hypogammaglobulinemia has been suggested as a risk factor as well. So the tests that are available for prediction, diagnosis of the disease and monitoring, there's a varied test, and culture actually tends to have very poor sensitivity. The shell vial is the one that's we to use rather than the conventional cytopathic ones, because there's much more rapid turnaround for that. But nonetheless, the sensitivity is poor, and the specificity is also of concern, because what we might be culturing is actually shed virus, as patients post-transplant can shed virus for long periods after the actual transplant. and in bronchial lavage this may just be viral secretions rather than actual disease. The two most useful are detection of the antigenemia using the PP65 assay and quantitative PCR. The antigenemia can be detected in various tissues such as the blood, plasma, as well as tissue and lavage, and this does correlate with the viremia. The PCR, we know that the viral load has significance. The higher the viral load, this has a risk for disease, although there's a lack of standardization and cut-off values is of concern. Tissue invasive disease requires diagnosis by histology and looking for inclusions, as well as possible immunohistochemistry and hybridization. But the important point here is that whenever you do monitor using the same test and monitor using the same sample type because of the variations that we do see. Immunoassays have been talked about a lot in recent years, and I think this is progressing very well experimentally and probably will come into the field of more routine clinical use. And what we're looking for here is T cells, cytotoxic T cells, which are specific to CMV, and looking for the detection of production of interferon or other cytokines. And what this here shows quite nicely is that those patients who retain that ability to have CMV-specific T-cell activation are much more protected in terms of their incidence of CMV disease following a period of prophylaxis. Now, just briefly talk about prophylaxis and preemptive strategies because they're the most used strategies. And some centres use one or the other, and this particular meta-analysis of 17 trials really showed that the universal prophylaxis, which is the initiation of treatment from the time of transplant in all patients or in a subgroup of higher risk patients for a period of 3 months or longer in some situations, or a preemptive strategy where you introduce the treatment by monitoring either the antigenemia or the virus in the blood. And what they showed here in this meta-analysis are both are effective basically, and there's no significance in their efficacy. They also showed that this preventative strategy reduced acute rejection, but notably the opportunistic infections and the mortality risk and so-called indirect effects of CMV were only impacted on by the universal strategy rather than the preemptive. And again, just going into that a little bit more detail, the prophylaxis strategy, fewer opportunistic infections, better patient and graft survival, and probably less risk of acute rejection. The problem with prophylaxis, and maybe the advantage of preemptive, is with prophylaxis, the emerging concern is that of late CMV disease and possibly drug-resistant CMV. Now, one way of trying to avoid the late CMV disease that we see with prophylaxis is to prolong the duration. And this study, which was the impact study, looked at 100 days versus 200 days. And we can see that this did significantly lower the incidence from 36 to 16%. And subsequently, it's been shown that this is cost-effective, although obviously you're using the drug for a longer period. And because you're using it for a longer period, there was concern about resistance, and this doesn't seem to be the case. So the international consensus, what do they recommend in terms of prophylaxis? Well, they recommend using ganciclovir or valganciclovir. Both are effective. Valgan, as you know, is the Valhalla ester and has a much higher absorption, bioabsorption than ganciclovir. 6 months for the higher risk group, the recipient negative receiving a donor positive transplant in kidney, liver, pancreas and heart. And 6 months also in all lung and small intestine transplants. 3 months in the seropositive groups, where you can also perhaps use preemptive strategy in kidney, liver, pancreas and heart. Some centres opt not to prophylax the seronegative recipient receiving a negative kidney. So just briefly around treatment, again, do we use IV ganciclovir, do we use oral ganciclovir? This was addressed by the Victor study, 3 weeks of treatment with oral or IV followed by 4 weeks of prophylaxis. And this was showed a non-inferiority result between oral valganciclovir and IV ganciclovir. Then, important to note here that the 74% of the patients in this group were kidney transplant recipients, and it was non-life-threatening disease in the majority. So the international consensus therefore highlights that, and therefore IV ganciclovir is still recommended in life-threatening disease where there's problem with any absorption of the drugs and in children. It recommends obviously ensuring adequate dosing, and this is based on renal function in children. Inadequate dosing has a risk of insufficient treatment and emergence of resistance. They also recommend monitoring the viral load weekly until you get at least 2 negative results a week apart, a minimum of 2 weeks treatment, and follow the treatment strategy with up to 3 months of secondary prophylaxis. Now, just moving on then to the BK virus. This is the same family as the JC virus, which is causes potentially fatal progressive multifocal leukoencephalopathy. In kidneys, it can also cause a very severe nephritis, like the BK, but with much greater fibrosis as well. The BK virus probably comes from the donor. It's latent in the renal epithelium. And there's an increased incidence of CMV as well in patients who contract BK, and this suggests that BK may be a surrogate of ovarian immunosuppression. What are the manifestations? Microhematuria, urethral stenosis, in bone marrow or stem cell transplants, hemorrhagic cystitis. It's an important cause of allograft failure, and those that contract it, 50 to 90% will see a loss of the allograft, mostly within the first 2 years, or subsequently between 2 to 5 years. Early detection of the virus may allow the prevention, since BK viremia occurs in 50% over the 3-month period post-transplant, and 95% of BK nephropathy occurs in the first 2 years. So clearly shown by this University of Maryland retrospective study that BK virus nephropathy does have a much greater attrition rate. 50% of grafts are lost in the 5-year period after the diagnosis, compared to patients who had normal histology as far as BK nephropathy was concerned. The risk factors are elderly recipients and donors, children, males, Caucasians. HLA-C7 negativity in recipient and donor seems to be a factor, and probably one of the most important factors, although we certainly don't routinely look at the titers of BK antibody in the donor. Other factors are related to seronegative recipients of positive donors, transplants, and HLA mismatch, delayed graft function, ureteric stents, and there's a suggestion to reduce the risk, to try and reduce the time interval of the stenting in kidney transplants. And the intensity of immunosuppression. The type of immunosuppression may not be as important, although there is data that's suggesting that tacrolimus probably has a much higher incidence than cyclosporine-based, and as I've mentioned already, everolimus actually may have a protective effect. CellCept or gain seems to be potentially more problematic in terms of the incidence of BK. Most patients and recipients are seropositive. A proportion of recipients, 30 to 50%, will develop virus in the urine, 10 to 20% viremia, and 1 to 10%, depending on the centre reporting their findings or data, is 1 to 10% for BK nephropathy. Now this shows the timeline of viruria, viremia, and BK nephropathy. And what seems to be evident is that you get a stepwise. You get viruria, then you get viremia, and then you get the nephropathy. And this gives you a window of opportunity in terms of screening and trying to identify those at risk. And viremia seems to occur for a median of 8 weeks prior to the nephropathy. So the screening could be using urine, decoy cells, just briefly. Difficult because these cells which show basophilic intranuclear inclusions in the epithelial cells shed in the urine are not as they're not maintained. They're lost very quickly, so it may not be as easy to detect those, and requires a great deal of effort and time on the part of your cytopathologist. So PCR in the urine is low specificity but high sensitivity. Electron micrography or Hofmann bodies for cast-like 3D polyomavirus aggregates has 100% sensitivity and 99% specificity, but clearly this is not available to the majority and still is an experimental tool. One of the most useful screening is blood PCR, quantitative PCR, but we're lacking standardization and we're lacking a cutoff value. Diagnosis of BK nephropathy standard has to be kidney biopsy and staining for the SV40 large T antigen, which is pathognomonic. And this is a patient that, interestingly, was switched from cyclosporine to tacrolimus 18 months previously following acute rejection, had a rise in her creatinine. She developed this interstitial infiltrate. The epithelial cells revealed these were enlarged with intranuclear basophilic inclusions, and the SV40 was clearly positive. She subsequently did very well on discontinuing the mycophenolate and also received some IV immunoglobulin at this time. Screening is recommended by KDIGO, and a lot of talk about cost effectiveness, but really I think a lot depends on the estimated incidence in your own centre and what's available to you in terms of screening. But in terms of the ideal seems to be blood PCR, quantitative PCR, monthly for the first 3 to 6 months, 3 monthly until the first year, and possibly annually for the subsequent 5 years, since that's the period of greatest risk of developing BK nephropathy. And also recommend screening after any acute rejection. Interventions, immunosuppression reduction, switching immunosuppression or adjunctive treatments. Reduction obviously depends on a cut-off value for your BK PCR, which most centres are suggesting it should be around 10,000 copies per mil. And the strategy, reducing your or stopping your antimetabolite and reducing the CNI level and dosing. Switching has been done, and there are studies available to suggest that the benefit of switching from from tacrolimus to cyclosporin, and also from Cellcept to azathioprine. Adjunctive therapies, I think still we have to say there's no definitive data. And the most influential study came from Brennan in 2005 in terms of reducing immunosuppression, where they discontinued the antimetabolite, reduced the CNI, and had very good outcomes at 5 years with no increased incidence of acute rejection. And this data from UNOS showed us that looking at patients with BK nephropathy who were treated with adjunctive treatment compared to controls, that only reduction in immunosuppression seemed to equalize the risk of graft failure, and all the other modalities had no significant benefit. In fact, patients did as expected quite badly with their BK nephropathy. So second presentation, just briefly if I may, 22-year-old lady. She had a transplant in October 2009. She was serostatus positive for CMV and EBV.
You have 2 minutes.
Okay, she was induced with basiliximab, and maintenance immunosuppression was TAC, MMF and steroids. Prophylaxis was Septra and Valsite. Sorry, I should highlight the EBV, rushing. The EBV was, she's seronegative and the donor was positive. The valganciclovir was for 6 months. She had a biopsy in 3 months after the transplant, renal biopsy. She had T-cell rejection. She was treated with pulse methylprednisone. Follow-up biopsy, persistence of that, further pulses of methylprednisone. In May, she presented with viral syndrome with fever and myalgia. Her creatinine had increased slightly from a baseline. CMV screening was negative. PCR was elevated at 114,000. And at this stage, the MMF was reduced. Her symptomatology seemed to settle quite rapidly with that, resolution of symptoms. And she went away. She came back about 2 months later, this time fever, nausea, vomiting, and epigastric pain. She was anemic. Her creatinine had grown up further to 174. TAC levels were around 3 to 5. She went on to have a gastroscopy. This showed very nasty multiple large ulcers in the stomach with raised folded margins and this necrotic base, and most likely malignant, sadly likely gastric lymphoma. She went on to have histology. Histology showed the separation of these glands by lymphocytic infiltrate. CD20, that's B-cell staining, was positive, and in situ hybridization confirmed the presence of EBV. So a diagnosis of monoclonal large B-cell lymphoma, PTLD, with subsequent cytogenetics was confirmed. Her immunosuppression was obviously tailed off completely. She had antimetabolite was stopped. The tacrolimus was significantly reduced, ultimately stopped. She was initiated on CHOP treatment, which is cytotoxic, with rituximab. She went into remission. During that period, follow-up gastroscopy of the 1 year was clear. CT imaging initially identified only very limited extranodal lymph nodes, and the CT remained clear. She lost the graft, unfortunately, with the development of BK and acute rejection. So I think I'm running out of time in terms of going through, but just to briefly, if I can highlight, the EBV and PTLD is one of the most seriously and potentially fatal complications in transplant recipients, probably the most common malignancy after non-melanoma skin cancer and cervical carcinoma. And I think a lot depends on what the histology is we see. Risk factors, I think one of the risk factors, the biggest risk factor is what I've highlighted in the case report, which is a seronegative patient receiving a seropositive organ in terms of EBV. And the organs are very important. Small bowel, multi-organs, much greater than liver and kidney. And detection of viral replication has some implication potentially, although one can't automatically jump to the conclusion, but there seems to be some risk associated with that. And KDIGO does recommend screening for EBV. I must admit our centre doesn't do that, but I think we need to focus on these higher risk patients, which we may avert the kind of possible the difficulties that we see with some of these patients. Treatment, again, very exemplified by the case report. It depends very much on the histology, reduction in the immunosuppression. A lot depends on the organ that's involved, and I think one has to assess the risk of the graft loss to the patient with the treatment of the PTLD on the background of the histology. Various treatments. Sirolimus conflicting data, people talked a lot early on about its potential benefits. But the important thing is the team approach, the infectious disease oncologist and transplant physician. So if I can end with the summary slide. It's an ongoing challenge, I think, to achieve a balance of protecting the graft from immunological injury and risk from any viral infections and disease. I think development of international standards for some of these molecular assays is essential, and we need to set these cut-off values. Virus-specific T-cell assays, which I briefly mentioned, using quantiferon ELISpot assays, may allow us to target individuals at greatest risk. And new immunosuppression agents, I think we still need to proceed with caution, but recognize also that some may actually have a more beneficial effect. So my take-home message really is risk stratify your patients and always maintain a high level, clinical level index of suspicion. Thank you.
Thank you, Dr. Abeed. And any question, please? Yes, Dr. Nasrallah, and then Dr.
Dr. Pall, my question, you know, leflunomide, we used it in BK virus because of the combined effect, immunosuppression and antiviral effect. Now, can we consider everolimus and mTOR inhibitor for this usage, given the background theory and the clinical value in preventing and inhibiting the viral replication?
Theoretically you can, and people have done that, but I think the clinical data and data from many studies that have been undertaken have come out not suggesting any potential benefit from that strategy. And I know people do it, and it certainly was tried. In fact, on the case that I just briefly showed you the histology on, it was certainly tried in that case as well. But I'm not convinced, I think, that we have enough clinical data to support that. Probably a theoretical, you know, it should do well. It should do well in terms of avoiding the rejection as well.
Yes, please.
Thank you very much. Nowadays we are seeing BK virus mainly very early after transplantation, maybe after very few months of transplantation. And the backbone is to reduce the immune suppressive therapy. So we have to expect rejection to occur. What is the reaction, especially if there is still a lot of juice in the kidney, still early on, kidney is taken from a relative, what will be the reaction at that time? Development of acute cellular rejection.
Yeah, that is one of the difficulties of reducing the immunosuppression. And the other difficulty is in terms of histology. Sometimes we don't know whether it's rejection or whether it's the inflammation associated with the BK virus. And I think there have been reports that clearly show that the inflammation that you see may, although it resembles rejection, it may even borderline on tubulitis, that it's actually related to the BK virus. And I think there's at least been case reports of antibody-mediated rejection appearances resulting from BK causing vascular involvement. So I think it's a very difficult one to try and differentiate between the two. One strategy that I employ, and I know many clinicians employ, is to use IV immunoglobulin in that situation. If you feel comfortable, you may want to go for a low dose of methylprednisone initial treatment whilst covering with IV immunoglobulin as well. So it's a difficult one, and I think that's where people tend to end up losing the graft in trying to get that balance. So I don't think there's any clear answer, but I think, you know, you will not do any harm, hopefully, by giving them immunoglobulin in that situation. Sorry.
But in the Middle East, I'm asking about your own practice. You are working in the most prestigious hospital in the place.
Sure.
So
that is my practice. So my practice is if I see the biopsy and we've diagnosed BK viremia initially, we've tailed off the the antimetabolite, patient runs into problems with rejection and confirmed rejection. We're convinced this is rejection as a result temporarily related to that reduction in immunosuppression. What I will tend to do is maintain them off I won't reintroduce the antimetabolite. I would probably treat them at that point with pulse CBS, low dose of methylprednisone, and follow that with some IV immunoglobulin. That's what I've done previously. Another strategy I've employed in a very difficult patient was subsequently down the road, if that persisted, that we've still got active viremia, we're still having problems with rejection, I've transferred the patient across from to an alternative strategy of cyclosporin, azathioprine and prednisone, and that individual patient actually did very well with that strategy. We were able to control the rejection and we were able to clear the viremia as well. So it's a complicated thing, and you have to juggle with the various issues that you have to have available to you as well.
Thank you.
Thank you. Any more questions? Thank you very much again for Dr. Abeed Pall and Dr. Brewitt and Dr. Karkar for the nice presentation. Just announcement, please reminded everybody about the gala dinner at 8 p.m. tonight, and the bus available at the hall, and the map as well will be available outside the hall. Thank you very much, and we'll see you then.